Well, good afternoon, and firstly I'd like to bring greetings from London and thank the organisers for the invitation to be here. It's my first visit to Berlin. I'm also aware that if I take too long, the audience may lose interest, and I'm very impressed that you're still here, but I don't think it's the subject that I have to speak about. I think you're here because of the possibility of beer and a jazz band. I'm also aware that if I take too long and the beer goes warm and the band goes cold, I will be very unpopular and may not be invited back. So aortopulmonary windows, well, you go to the literature to search and not much turns up. So I have no disclosures, but it doesn't matter. I have an Irish passport. So I'm very proud to be a European, and I can only say that I am seriously embarrassed at the results of the referendum of 2016. So, aortopulmonary windows, what is it? It is what it says. It's a direct connection between the ascending aorta and the pulmonary artery or its branches, and it is generally considered to be a congenital lesion. It is rare. Looking at the CCAD, that's the Central Cardiac Aorta Database that records all activity in the United Kingdom. In the period of covering 3 years of 8,700 operations in children under 1 year of age, there were 28 cases. But because it is so commonly associated with other defects, something like an interruption may be listed as interruption rather than an AP window, but it still underlines the fact that this is a rare defect. So, as I say, it is often associated with other defects, and a report from the Royal Brompton Hospital of 25 specimens in their pathology museum showed that these were the associations. Only 4 cases were isolated AP window, otherwise interruption was frequent: coarctation, transposition, tetralogy, DORV, and VSD. And in my own career, I have seen all these associations. But of course, what we must remember that this, published in 1994, represents a pathological collection. So in other words, those who died. So we don't really know of what the incidence would be associated with those who survived. And I suspect the isolated window does rather better. So the presentation, it may be picked up on fetal scanning, but for those that are born, because of the high pulmonary resistance immediately following birth, it may be asymptomatic, but as the pulmonary resistance starts to fall, you will get the features of cardiac failure, tachypnea, tachycardia, sweaty, poor feeding, and failure to thrive. And of course, the associated lesions may be the presenting feature if it is transposition, tetralogy, or an interruption. So the diagnosis, well, echo is the mainstay of diagnosis, but if there's any doubt about the anatomy and connections, we would use CT or MRI scanning, particularly in the context of associated lesions. Cardiac catheterization is now really used for late presentations to assess pulmonary vascular resistance, and otherwise really plays little part in the management of this condition. And the treatment, well, close it. Surgery as soon as it can reasonably be arranged. If, of course, there are associated lesions like interruption, then it'll be necessary to maintain a prostaglandin infusion. And if there's a transposition, it may well be appropriate to do a septostomy. And so the associated lesions may actually be those that determine the timing of the operation. But for an isolated lesion, it's often within the first month of life. So, as I say, they can be picked up on fetal scanning. This is an example. Or postnatally, connection, as you can see, between the ascending aorta and really the more distal main pulmonary artery. Here's a pathological specimen beautifully illustrating, and these things are really rather large. And this is just looking at, this is the ridge between the aorta here and the main pulmonary artery, and you can see the arch going off here, left pulmonary artery, and the right going around there. People have tried to do a classification, and there are several, mostly 1, 2, and 3, or 1, 2, 3, and 4, or 1, 2, 3, and intermediate. You'll get the drift. I'm not a fan of classification. Another one, I think this comes from Brazil. This should stick to football. So classification is unresolved, and really it's such a rare condition. Trying to classify it, to my mind, is a pointless exercise. And really what should be done is for the surgeon to describe accurately what you see at the time of the operation, rather than trying to fit it into a classification, because undoubtedly some of these conditions, these rare conditions particularly, will overlap from one to the other. And it can sow complete confusion if you, in your mind, think about type 1, and somebody else is totally confused and thinks that type 3 is actually type 1. Then you're on your way, and that confusion will persist forever. So the repair now, rarely, and I've never seen one, I wait for it, you can get what is effectively a bit like a ductus. So there is some length to it. And so treatment will be to isolate the defect, apply 2 clamps. And what I will say is, when you, as a surgeon, look at this kind of thing, you say, oh yeah, we can deal with that, clamp, divide and oversew it. You've got to realize that once the clamp is in position on one side and a clamp on the other side, that there may actually be very little tissue to put a suture in. So any surgeons in the audience who are tempted into clamp and divide, it can, when you've put the clamps on and you've cut through it, you realize you've got nowhere to put a stitch other than through the clamp, and that's not a very effective treatment. At least my coronaries won't take it anymore. But it is recognized, and that's an example. More commonly, they really have no length, and it is truly what it says it is, a window. So first, that you're going to have to go on to cardiopulmonary bypass, and the first thing is to cannulate the aorta high up. You really need to get up, or if necessary, get round the arch, because you will be surprised at how little room there is once the cannula goes in, and you're then trying to put a cross clamp on in order to administer cardioplegia and open up the aorta or pulmonary artery safely. So once you've got it out, you're on bypass, you've got to give the cross clamp. Now what you're going to have to do is occlude the pulmonary arteries, because if you put the cardioplegia straight into the aortic root in the way you would normally do, it'll all disappear into the lungs and the heart won't stop. So it's the same as with a common arterial trunk. You'll have to occlude and snare off or clamp off the pulmonary arteries in order to arrest the heart. If you've got incomplete arrest, you can open up and deliver the cardioplegia directly down the coronary arteries as an alternative, but one way or another, the administration of cardioplegia can be problematic. Having done that, there are various methods of closure. I prefer the simplest method, and here is a kind of variation on it. It's known as the Johansson technique. And so a single patch is placed within the window, and then the patch is brought out through the incision, and it is closed as a sandwich. The only thing that the surgeon needs to be careful of is that the coronary artery is on the aortic side, because the right coronary artery can sometimes be displaced towards the pulmonary artery, and if you're not careful, you may find that you end up with an R kappa after your operation. So having closed it, get the air out, wean from bypass, measure the pulmonary artery pressure, do an echo to make sure that you've got complete closure, and return the patient to the intensive care unit. This is an example of a case of my own. I was operating in Africa, was presented with a case that was said to be subaortic obstruction. Well, there was subaortic obstruction, but the gradient was out of proportion to what I expected. And when we opened up, lo and behold, there was a big AP window in a 4-year-old. Anyway, it was successfully closed. Instead of the sandwich technique, the alternative shown here is simply to make an incision into the aorta and then sew a patch in and then close this incision. Now, others prefer to separate, and so they will divide it and then use 2 patches. The problem with this is that, especially in the very small and immature neonate, you'll get bleeding because blood doesn't clot as well in this age group. So I would only use this in the context of a hypoplastic arch or something like that. But the big question really, I suppose, is what to do with the late presentation. And these will show up, particularly in low-income countries in the developing world. And first thing will be to try and establish whether there is some reversibility of the pulmonary vascular resistance. Clinical features, if they're still mostly on echo, left to right flow with minimal right to left, then that's probably fine. If there are features of congestive failure, then that's also likely to be successfully closed. But beware of the thriving child, the child that was failing to thrive, who then, true of all these left to right lesions, VSDs otherwise, that was going through a period and then starts to put on weight and feeding well. They do so because they're developing pulmonary vascular disease. But this is one of the techniques that was discussed this morning, and I've used this for a 14-year-old who came to us from Kosovo, and it's a flap valve. This is described by Bill Novick and was effective. But I noted this morning in discussing late presenting VSDs, it is true that when you first come off bypass, the pulmonary artery pressure may be very high, and that is not a reflection of the lesion itself. It is a reflection of the impact of cardiopulmonary bypass on the pulmonary vasculature. And if you just hold your nerve for a few minutes, 20 minutes or so, you'll find that it'll start to drop if everything else is in good shape. Moving on to the associated lesions, this is the most common, probably is interruption, and this was published work. We're really not able to get a handle on what the frequency of association with interruption is. But this was published by the Society of Thoracic Surgeons. How do we deal with it? Well, again, obviously you've got to go on to bypass. For interruption, I just use a single cannula, but obviously if you snare the pulmonary arteries, in the context of an AP window, you will perfuse the lower body and then take the temperature down to whatever you prefer. If you want to perfuse the lower body, it just complicates. I don't like a lot of tubes in the way when I'm trying to sew. But the first thing to do is to deal with the interruption by whatever method suits. Here they've done a direct connection. I'm always slightly concerned about that. And for interruptions, we tend to prefer nowadays to bring it together, and then rather than bringing the descending aorta all the way across to the ascending aorta, which can cause compression of the left pulmonary artery and the left bronchus, and of course is a horrible problem, is to augment this area with a homograph patch, somewhat in the manner that as we would for a Norwood procedure. So long term, those that are isolated seem to do very well and are generally free of any major issues. And it's no surprise those described as complex, i.e. associated with things like interruption, transposition, or tetralogy, have other issues. And their freedom from re-intervention again reflects this. It's actually quite rare to need to do anything to the pulmonary arteries, which are usually much larger and so seldom cause late problems. But of course, all these issues of re-intervention, if it's interruption, transposition, fallows, and so on, will be reflecting that. So, I've already spoken about something that is pretty rare, onto something which is incredibly rare. I qualified in 1979, and I started in heart surgery then. And since then, I have seen one case of aorta to LV tunnel. So if you're hoping for an expert opinion on the subject, if there's anybody in the audience who's got 2 cases, then you can take over. So what is it? Well, it's what it says it is. It is a communication between the ascending aorta and the left ventricle. It is very rare, and some estimates put it at probably somewhere in the range of 1 in 10,000 of cardiac defects. So most of us probably in our working life will actually never see one. It's generally considered to be a congenital defect, but is it an acquired defect in utero? Now, a true aorta LV tunnel, I think, is congenital, probably by virtue of the fact that it is present when we are born, but it may well be a developmental issue. But there is a theory that it possibly is a coronary artery fistula with a sort of variation, but that too is a congenital defect, but coronary artery fistulae rarely ever go to the left ventricle. Is it a sinus of Valsalva fistula that has ruptured in utero? Again, they rarely rupture into the left ventricle. Usually it's either to the right atrium or to the right ventricle. So I think that that is probably not the etiology of it. So why is an aorta to LV tunnel not simply another sinus of Valsalva fistula? Because it arises above or at the level of the sinotubular junction, whereas a sinus of Valsalva fistula really arises deep in the belly of the sinus of Valsalva. So here are some pathological examples of the tunnel, which runs down. Here's the pulmonary trunk. And then opening up the left ventricle, it enters down in here. This is not very close yet, but very clear. I can't see this terribly well myself from this angle. And the ventricular end is itself is isolated, or is located in the interleaflet triangle between the right and left coronary sinuses. And that seems to be a very constant feature of the aorta LV tunnel. These diagrams just show that how they're rising above this and then through, and this space between the right ventricle and the infundibular septum is preserved. Oops, got my... So the diagnosis, it may be picked up in utero, and the only case I have seen was a fetal diagnosis, and someone was discussing with another one pending here, also diagnosed in fetal life. And here you can see that this one has sort of aneurysmal connection, the right coronary sinus, and I can't actually define the tunnel from this view. And here, of course, is a sinus of, that was a sinus of Valsalva aneurysm. And here a sinus of Valsalva fistula, and you can see this sort of windsock of tissue that can be withdrawn back into the right coronary sinus or the non-coronary sinus to indicate the nature of the defect. I've got to get... So here's another one presenting, and this is arising from the left coronary ostium in a 2-year-old. And as I say, I think that these probably represent a coronary fistula rather than the sinus, because it's really connecting from the coronary rather than the thing. But these are all published and claimed to be aorta LV fistula. Well, in a technical sense they are, but I don't think it's the same entity as the true aorta LV fistula. And here are right coronary to left ventricular fistulae, and I think these are genuine coronary artery fistulae. But most coronary fistulae actually end up in the right atrium or right ventricle, and so to the left ventricle is not common. There can, of course, these fistulae be exceedingly large. So the theories of etiology, and they are just theories, that it's an abnormality of the coronary artery, that it's a malformation during development of the bulbous cordus. Well, I suppose yes it is, but how it emerges is pure conjecture. It's a weakness of the aortic wall. Again, yes, it is, but that it represents an intrauterine rupture of an aneurysm of the sinus of Valsalva. Well, I don't think that's so because, as I said earlier, it arises above the sinus, really at the sinus-tubular junction. That it's an early intrauterine dissection associated with Marfan, or as in Marfan's. Well, neonatal Marfan's is a pretty appalling disease, and if they're rupturing in utero, I don't think that that's a reasonable explanation. Persistence of the embryonic crest of the fifth arch. I know there were 5, 6, but don't ask me any more. And the truth is, there is as yet no reliable theory of how it develops. So again, there's attempts at classification, and it's so rare that for anyone to accumulate enough to be able to then group them into classifications and then on the basis of that to talk about how frequent the individual types are, I think is utterly fanciful, but it hasn't prevented someone trying to get their name into history. That's usually why classifications occur. Somebody wants to go down as the next Fallow or whatever. But again, I say they're not really of much clinical use, and it is much better to precisely describe what the pathology actually is and what is seen at the time of surgery. So the diagnosis, well, as I say, it may be found on fetal ultrasound. Otherwise, depending on its size, there may be neonatal symptoms of cardiac failure, the usual tachypnea, tachycardia, intercostal recession, clearly there'll be diastolic murmur of what is effectively aortic regurgitation, although it is paravalvar, a very wide precordium, the wide pulse pressure and low diastolic pressure. And diagnosis is almost certainly based on echo. Flow reversal in the aorta will give an indication of how severe the regurgitation is, and CT or MRI angiography, if there's any doubt, to try and establish its relationship to the coronary ostia, because the coronaries sometimes can be very closely related to it. Again, cardiac catheter is almost certainly redundant, and the instability of these patients probably mean that they won't tolerate a catheter. So here we can see the tunnel running around past the leaflet of the right coronary, and of course massive flow through it. A short axis view of the tunnel. So the treatment, well, the first thing really is to manage the failure. And so if there's a baby born with one of these things and is in trouble with breathing difficulties, you'd have to get it onto a ventilator if necessary, anti-failure treatment, perhaps some inotropic support. But really, you're going to have to repair this and close the tunnel in order to control it. So severe symptoms will mandate early surgery. The operation, obviously, is going to have to be on cardiopulmonary bypass, single venous cannula, return to the aorta, cool to whatever temperature the surgeon feels it favors, and then an incision. Well, I mean, some people like deep hypothermia, others like normal temperature. A transverse aortotomy just above the sinus-tubular junction, and then you're going to have to give cardioplegia directly into the coronary arteries, because if this thing is large, it won't get to the coronaries. You may need to vent the left ventricle in order to get the left atrium in order to get a clear view without blood welling up all the time, and then open the tunnel to see the left ventricular end. But you may be able to see it through the aortic valve, But you do need to see both ends, because the treatment advised by all who have reported on this is to patch both ends and take care to protect the right coronary artery and, of course, the right coronary leaflet of the aortic valve. On table, epicardial echo for small children. If you have access to a microprobe, then a transesophageal echo, of course, is useful. This is just an operative picture, and you can see this bulge here, which represents where the tunnel is. And so, schematically, open the aorta. You're looking at this thing here, the left coronary, right coronary, pretty close by. And you want to really try and patch off at both ends of it to exclude it thoroughly, because if you don't close this end of it, you'll get ejection into it. If you don't close the other end of it, you'll get regurgitation into it. And so double patching is really, for that reason, is necessary. So there are some case reports of later on, and this is a 40-year-old described. And as I say, when I hear there's a 40-year-old with this condition, I'm slightly skeptical. But actually, when you look at the echo images, it does appear to arise high just above the sinus or at the sinotubular junction, and to empty where the tunnel would normally expect. But it is clearly restrictive, and so that is probably why it has been controlled to this time. You can see here on this reconstruction. And this is an operative image of this case associated with the bicuspid aortic valve. Others are described in association with the right coronary ostium. Post-operative care, well, if the operation's gone well, the tunnel is closed, they should be relatively easy to care for. Standard intensive care, surgical post-op cardiac surgery management. Mortality has been quoted somewhere in the range of 10 to 20%, but that may reflect the era within which it occurs. In the long term, there does seem to be a high incidence of aortic root dilatation, and the only case that I have in my own experience, it was in the year 2000 that she was born, and at the age of 15 had developed an aneurysmal aortic root with aortic regurgitation and had to undergo aortic root replacement. And that is a frequent comment that you see in the case reports or the small series that have been published. So with that, my thanks to you. This is the institution where I work, Guy's and St. Thomas's, and that is the Evelina Children's Hospital. Thank you for your attention.